In the fag end of May 2025, that was last month, several reports about the death of 8 people who had undergone dental treatment in a dental clinic in Vaniyambadi started appearing in the mainstream media outlets. The source for these reports were attributed to an article published in the Lancet. As a clinician, I was curious to find out how such a gross oversight of infection control happened. I hoped that by reading this article, I would get an insight into how to protect my patients from such an incident. However, as I read through this article, what I discovered was deceptive verbiage, half-truths, manipulation of facts, and blanket statements made without any corroborating scientific evidence. What follows is my critical review of the article titled Neuromelioidosis Outbreak in Tamil Nadu, India, an investigation of transmission with genomic insights. Please excuse me, I'll be reading this critical review from a written script in the interest of accuracy and time. B. pseudomyeli, the bacteria that causes melioidosis, is a primary soil saprophyte. Its usual mode of transmission is either through inoculation through skin or ingestion or inhalation. The only case of iatrogenic exposure to B. pseudomyeli cited by the article is a case of a 63-year-old doctor who probably contracted the bacteria during a dental procedure due to contaminated water line. This is reference number 8, and this is a small detail that should be remembered for later. On May 9, 2023, CMC Vellore notified the state health authorities of an increase in the number of neuromelioidosis cases. They found that some of these cases were linked to a dental clinic in Vaniyambadi. During my first read through of the article, I assumed that CMC Vellore saw an increase in the cases of neuromelioidosis reporting to their OP and found several of these cases to be linked to a dental clinic in Vaniyambadi. However, in truth, only 2 cases, a married couple, had reported to CMC as stated later in the article. One would also not be at fault in assuming that CMC Vellore were the first to detect the outbreak and report it to the state health authorities when first reading this article. However, in the same paragraph, the article also states that there was a newspaper report that reported suspicious deaths related to treatment in a dental clinic. This is reference number 28 in the article. It is a website link to a news article on DT Next website. DT stands for Dinathanthi. Now let me just rephrase this so that you understand it better. A scientific article published in the Lancet has just used a website as a reference. This is a practice that is even frowned upon in postgraduate curriculum. What was more damning was the contents of this newspaper report. This newspaper report, which is dated 1st of May 2023, makes reference to a poster containing the names of 9 people who had allegedly died after treatment by a dentist being pasted in front of his clinic. This is a detail to be remembered for later. This newspaper report also mentions that the Joint Director, in a letter dated April 2025, had stated that an inquiry will be conducted at the dental clinic on the 4th of May 2023. All of the above events have happened long before CMC Vellore on May 9th reported the 2 cases who had come to its hospital. Furthermore, nowhere in the newspaper report are the words suspicious deaths used. They clearly state that the cause of death is either brain death or coma. The term suspicious death is usually used to refer to death due to unnatural causes like murder or homicide. This is the first of many examples of the authors of this article using selective omission of facts and deceptive verbiage to set a narrative to incriminate the dentist as the root cause of this outbreak. Let's move on further. Under the ethics statement section, the authors state that their investigation was approved by the Institutional Review Board of ICMR. The authors seem to have completely bypassed the state health authorities for any approval or permission. In fact, if the current news reports are to be believed, it looks like the local health authorities have been taken completely by surprise by this article and the media response to it. That said, how they were ignorant of the contents of this article when the Directorate of Public Health and Preventive Medicine, Tamil Nadu, India appears in the authors section of this article is a valid question. The bigger question is, if they were aware of the contents and conclusion drawn in this article, why had they not taken any action against the dentist and the dental clinic in the last 2 years. Now let's move on to the section titled The Strategy of the Outbreak. The article states that a married couple came to CMC with symptoms consistent with neuromelioidosis. The date on which the couple reported to CMC is not mentioned. It further states that simultaneously local newspapers reported multiple deaths among patients treated at a dental clinic in Vaniyambadi. This we know to be the May 1st newspaper report cited in the reference. The local JD office had already initiated action against the clinic. Now the question that arises is CMC Vellore knew of this outbreak at the same time as the newspaper reports, namely on the 1st of May 2023, then why did they wait until the 9th of May to report the outbreak to the state health authorities? Did the massive public outcry and media exposure have anything to do with this decision? On page 4, the article states that initial clues pointed to patients who had undergone invasive dental procedure at a dental clinic experiencing illness. They had spoken to the dentist and had conducted an environmental investigation at the clinic. This involved swabbing the dental equipment, common areas, water taps, sample medication and irrigation fluids. We now know that all of this was done about 1.5 months after the initial report and after the local health authorities had given a clean chit to the dentist. The article conveniently fails to mention this critical passage of time. It only mentions that at the time of environmental sampling, the clinic had been disinfected, water supply cut off and closed following public outcry. They claim that they isolated B. pseudomeli from an in-use saline bottle that they collected from the clinic. One may be justified in asking how a saline bottle that had been lying open in a sealed clinic for the past 1.5 months can be labeled as in use. One may also be justified in questioning the legitimacy of a sample so collected. Also, why the discovery of B. pseudomeli in the saline bottle is mentioned in the materials methods section while it should have been mentioned in the results section. Let's move on to the results section. The article reports that 21 cases of neuromelioidosis were identified in 4 districts between July 2022 and April 2023. Of these 21 cases, 10 cases had a history of undergoing invasive dental procedure that required the injection of local anesthesia and repeated irrigation with saline at a dental clinic. No mention of what these invasive dental procedures were is mentioned anywhere in this article. The article omits this crucial detail but finds valuable print space to mention the public outcry against the dentist. The article also mentions that more than half of the cases with a history of dental treatment also reported frequent contact with soil and surface water. Now let's recall that B. pseudomeli is a saprophyte that is native to soil and surface water. The actual number of cases with multiple sources of potential exposure has not been mentioned in this article. The article further mentions that B. pseudomeli was isolated from only 3 of the 10 dental cases. How many of these cases also had exposure to soil and groundwater is not mentioned. Culture analysis of CSF samples were negative. Now moving on to a section titled Confirmation of the Source of Infection, we are presented with the most damning evidence of the internalized bias that has motivated this article and the complete lack of knowledge regarding how dental procedures are administered. It is stated, and I quote verbatim, "The clinic was staffed with a dentist, nursing staff and receptionist. None of them had any formal training in hospital infection control." This is stated verbatim in the article. This blanket statement is made without any corroborating evidence. How is it that such senior and learned physicians who are the authors of the article, all 46 of them to be exact, don't know that infection control is part of the undergraduate curriculum of both dentistry and nursing? The authors then go on to state, and I quote verbatim again, "Normal saline supplied in sterile 500 ml plastic bottles are used for wound irrigation during surgical procedure as well as for dilution of local anesthetic used for infiltration. At no point in my last 20 years of dental career have I ever heard of local anesthetic solution being diluted with saline for any procedures. This practice is not in any way standard practice in dentistry. This statement is made with no corroborating evidence. This section is also the part where the dreaded periosteal elevator makes its first appearance. The article states again, and I mean verbatim, these bottles were opened using a non-sterile periosteal elevator, loosely resealed and used over subsequent days until they were empty. How this dreaded periosteal elevator was first infected with a bacteria that is native to soil and groundwater is not explained by the authors. They also don't present any evidence to suggest that they collected any swabs from the periosteal elevator or if these swabs were tested positive for B. pseudomyeli. It is not unfair to expect a bacteria that survives on an open saline bottle in a closed clinic for 1.5 months to also survive on a periosteal elevator that was never sterilized and only washed in running water. They also state, and I quote verbatim again, an increase in failed dental procedures and complications were reported during this period when neuromelioidosis cases started to occur in the district. No mention of what these failed procedures were or how these procedures failed is mentioned in the article. How the authors of this article came across this information is also not mentioned in this article. Furthermore, none of the authors of this article are dental experts. The article does not make any mention of consulting an appropriate domain expert in this regard. Is one expected to just take the word of the authors as gospel in spite of them not providing any scientific evidence to support their statements? 28 environmental samples were collected by the authors from the dental clinic, from which the authors were able to isolate B. pseudomyeli from only one in-use saline bottle. No mention of collecting any samples from the dreaded periosteal elevator or isolating B. pseudomyeli from the same periosteal elevator is made anywhere in the article. Further, B. pseudomyeli isolated from the brain tissue of the first dental exposure showed clonality with the isolate from the saline bottle. The authors were able to get 3 samples of bacteria from the sporadic series of cases, namely cases that had been infected by exposure to groundwater and soil. They were able to get 1 sample from the first dental exposure case and 1 from the accused saline bottle. In the author's own words, all 3 isolates were 100% clonal. I am a bit confused here, as if all 3 isolates are 100% clonal, would it be fair to assume that there is no conclusive evidence to prove only iatrogenic exposure in a dental clinic? More such self-contradictory and baseless statements are made in the discussion section of the article. It is stated, and I quote, "Those with dental exposure showed rapid progression, presenting with facial cellulitis, soft tissue abscess. These clinical features suggest pathogenesis through oral mucosal ingestion or inoculation with contaminated water leading to infection." Here, one must recall that the article in an earlier section had mentioned that more than half of the dental exposure cases also had routine exposure to soil and groundwater. So, this mucosal ingestion and inoculation could have happened from contaminated water from environmental sources also. The article also states that the isolation of B. pseudomyeli from a saline bottle at the implicated dental clinic in May 2023 and its clonality to the isolate from the brain tissue of the first dental case in December 2022 strongly suggests an iatrogenic common source of exposure. Again, one should recall that in an earlier section of the article, they had stated that all isolates collected from the sporadic cases, the dental exposure case and the saline bottle were 100% clonal. This statement, along with the statement that more than 50% of the dental exposure cases also had exposure to groundwater and soil, directly contradicts the above statement that clonality of isolates from the saline bottle and brain tissue of the first dental case being strongly suggestive of an iatrogenic common source of exposure. The article further states that saline bottles were often opened using available tools and washed in tap water. Please note here that the periosteal elevator that was mentioned in the previous section has been replaced with available tools in this section. The article does not state if any of these stools were swabbed or if B. pseudomyeli was isolated from any of them. The article further states, inadequate IPC practices at the clinic, as evidenced by observation, might have facilitated contamination of the dental instruments from the dental unit water system, potentially exacerbated by prevailing post-monsoon conditions. At the risk of sounding like a broken record, I have to note again, the article does not mention the collection of any swabs from the dental unit water line or the isolation of B. pseudomyeli from the same water line. Furthermore, the article previously stated that the last two cases suspected of dental exposure, namely the married couple who reported to CMC, had reported to CMC in May. If you are someone who lives in Tamil Nadu, you will know that the weather in May is anything but post-monsoon. It is further stated in the article, and I again quote, notwithstanding the above proposition, we cannot rule out any contamination other than the above mentioned environmental source. The lack of availability of dental clinic registered limited us from determining the number of individuals exposed to contaminated saline. If the above statement is true, then how did the authors conclude that exactly 10 out of the 21 cases reported between July 2022 and April 2023 had a history of invasive dental treatment? Is there only evidence for this number come from the DT Next news report that they had cited as a reference at the beginning of this article? This news report in turn has made mention of a poster pasted in front of the clinic mentioning the names of 9 people who had died after treatment in the clinic. Is there only evidence for the number 10 absolute hearsay? Now there are other ways to confirm if a patient has visited a clinic, namely bills, payment receipts, prescriptions, etc. It is quite surprising that these avenues were not pursued by the authors. Now I would like to stop here. However, I would like to end with a few final questions. How did an article with so many flaws pass peer review by the Lancet? What was the last time you had come across a scientific publication with 46 authors? And why is the Liverpool School of Tropical Medicine mentioned in the author section of an article about outbreak in Vaniyambadi? Though very obvious, I will not state the conclusions of my critical review. I would rather encourage anyone seeing this to read the original article and then watch this video again. If I am in some way mistaken, I would immensely appreciate it if you can tell me why.